So hello everyone, I hope you enjoyed this surgery mock, and now I will be discussing this paper. So straightforward, going to the paper. The first question is, which of the following nerve is commonly damaged during McBurney's incision? So when we talk about McBurney's incision, where do we make this McBurney's incision? Over the right iliac fossa. So when we talk about the McBurney's point, which is medial 2/3 and lateral 1/3 of the spinomumbilical line, so perpendicular to this is the McBurney's incision. Now this is the domain for the classical iliohypogastric nerve. So when you talk about iliohypogastric nerve, the pain that is why might refer to the middle of the thigh, mid of the thigh, or the anterior portion of the thigh. It is during appendicectomy that iliohypogastric nerve is the most commonly damaged nerve. When you talk about ilioinguinal nerve, it is the most common nerve injury during open inguinal hernia. During laparoscopic, it is lateral cutaneous nerve of thigh, and thoracodorsal and long thoracic nerve are damaged during breast surgery. So this was one of a very straightforward question. The next is, a 45-year-old female presents with dysphagia, particularly too solid. She reports of sensation of food getting stuck into her chest. A diagnosis of dysphagia lusoria was made. Now, when we talk about dysphagia lusoria, what is the classical concept of dysphagia lusoria? Now, this is normally the right denominate from which the right common carotid and right, you can say, subclavian artery arises. So, this is right common carotid artery, straightforward arising. This is left common carotid artery. This is left subclavian artery. Now, you must be wondering, where is the right subclavian artery? So, do you know right subclavian artery might arise either from the left subclavian or distal to that from the descending thoracic aorta. So, now this is esophagus. Behind the esophagus in the prevertebral space, this artery goes, arches and reaches the right side. Now this is an artery, so there will be pulsation. So actually these pulsation will irritate indent on the posterior wall of esophagus, causing dysphagia. Now this is what is known as aberrant right subclavian artery or arterial lusoria, and that is why this condition is known as dysphagia lusoria. So amongst the option, they are asking what is it due to? Answer is aberrant blood vessel, which is aberrant right subclavian artery. Now again, if you see this image, this is an image where you see a goiter. A fine bossellated appearance goiter, a box-shaped goiter is seen. Which of the following is most likely diagnosis they want? So, a 28-year-old female presenting to you with the image, the TSH level were found to be elevated. So, this is a case of hypothyroidism with a, you can say, with a goiter, and along with that, the HPE shows to you lymphocytic infiltrate and Hurthle cell. The diagnosis is none other than Hashimoto's thyroiditis. Students, this is classical Hashimoto's. Otherwise, if you don't have the Hurthle cell or the lymphocytic infiltration, a lot of options can be considered. Which of the following statement is true regarding the retrosternal goiter? What is retrosternal goiter? It may be a goiter extending from the neck into the sternum, behind, you can say behind the sternum into the mediastinum. That is retrosternal extension of the neck gland. Or it may be a primary ectopic, you can say thyroid tissue turning goitrous. Anyways, when we talk about retrosternal goiter, they need to be removed. So operated only if the patient is symptomatic. This is partially true, but I would consider it false. Sternal incision is always required. Sternal incision is required only for the primary, you can say true ectopic glands turning goitrous. Majority of them are excised by a what incision? Neck incision. So if you see the option D, majority of them are removed by neck incision. This is absolutely true. So D is far better answer than A. Now, majority of the glands are arising from the neck, so they are not deriving their blood supply from the mediastinum. So option C is also false. Now, the next question is, being a medical student, you observe anal fissure and then the patient is taken for the surgery. Which of the following surgical position which was carried earlier on or which was used earlier on and it is avoided? Why? Because of positional asphyxia. So when you talk about this classical, you can say position, what is this position? So this is a prone jackknife position. So this is a prone jackknife position. And when you talk about prone jackknife position, the patient is, this is on the OT table. So patient is having a positional asphyxia. In all the three positions, Trendelenburg, lateral or Fowler's position, the patient is not having a positional asphyxia. So option D is absolutely right, the answer in this case. Now, when you talk about the suture material, they are asking the most tissue reaction is seen with which of the, you can say, sutures amongst the option. So sutures always create a foreign body reaction. The most inert is stainless steel and the most reactive is your silk. So option C is the straightforward answer. Catgut, polydiaxone, they all have reaction, but not as much as compared with the silk. Silk is a braided black colored suture. It's a non-absorbable suture. The next question is related to cholecystectomy, where a 55-year-old female presents with fever on day 4th. So basically we're talking about some leaks, some injuries, anything. Let us see. She also experiences tachycardia and hypotension and abdominal tenderness. So now one thing is there, that patient is in sepsis and shock. The CBC revealed elevated WBC count with a left shift. Although there is only mild tenderness, no redness at the surgical site. So this is not a surgical site infection. This is not cholangitis because obstructive jaundice is not there. Pancreatitis, this is not sufficient to diagnose pancreatitis. Now, what could be the most important reason? It's a septic shock which has occurred. So the option D is the answer. Next is again a patient of diabetic hypertensive patient going cholecystectomy. Then their blood glucose level is very poorly controlled. On day 3, he develops fever. There is a wound drainage for, you can say, and wound drainage from his, there is a drainage, purulent discharge from his surgical site. The examination of the wound shows a culture positive for Staph aureus, which is the most important thing that you will do. Continue the prophylactic antibiotic. This is not true, partially true. Start the patient on broad spectrum antibiotics. Yes, it is partially true, but it is more specific if you target with Staph aureus directed therapy. So debride the wound. We need to evacuate this purulent discharge. Otherwise, the pus will not allow the antibiotic to enter because they always form a capsule around the wound site. So debride the wound and start the patient targeting the Staph aureus, and this is what is the best answer. Perform a repeat surgery to remove infected tissue and start the patient targeting. Students, option D is very important. Why will you do repeat surgery? This is important. So option C and option D both seem to be right, but it is the D. They are asking to repeat the surgery. Why will I repeat the surgery? I'll only debride the wound. Next option is 62-year-old male receiving TPN therapy for EC fistula, intracutaneous fistula, develops high temperature and erythema around the central line. So this is a central line induced, you can say, infection. So what is the best thing? You will remove the line, establish a line at another side, and this line which you have removed, you'll send it for culture sensitivity. So proximal 5 centimeter, that includes the tip of the central line, should be sent. So if you see the options, remove the catheter, send the tip for the culture sensitivity and establish a central line at the other side. This is what is the answer. Begin broad spectrum antibiotics without removing the needles or the source. This is not going to benefit. So this is wrong. Obtain blood culture. This is right. But you need to remove the central line also. Remove the catheter, send for the culture, and IV line. No, this is not, because the peripheral nutrition, you can say peripheral, when we talk about TPN, TPN is given by a central catheter, not by the peripheral veins. Next is, when we talk about this question, if you don't even go to the question, they're asking, this develops the pathology from which of the glands? So if you see this image, this is floor of the mouth with a swelling, cystic swelling, and this is illuminating on, you can say, or this is showing transilluminance. So it's a ranula, and this is arising from the sublingual gland. So even without reading the question, I've been able to mark the answer. Next is, you see an ulcer over the lateral aspect of the foot, not the medial, but this zone is a gator zone which is prone to develop what, students? Venous ulcer. So this is a case of venous ulcer, and this A is the option here. Next is Cushing ulcer, curling ulcer are, you can say, trauma-induced or stress-induced ulcers, where stress injury in burn causes curling ulcer and stress injury in head causes Cushing ulcer. So option B is absolutely right in this case. Next is 45-year-old male with paralysis is operated for rectal prolapse. So you know that the image is showing a wiring done of the, you can say, perianal circulage done, and this is nothing but a Thiersch wiring. Now, this is not a stappled hemorrhoidopexy because stapler is not seen, and this is stapler hemorrhoidopexy is not a treatment for the rectal prolapse. It's a rectal mucosal prolapse basically. So, ultimate procedure, you will do a mucosectomy resection and then you will do the anastomosis. So, this is Thiersch wiring which is shown in the image. So, option C is the right answer. Now, I will not even read which of the following is the most probable diagnosis. The lady has undergone mastectomy with limb edema on the left side, and this is because of the damaged lymphatics. So, amongst the option, let us see, this is option A, which is far better than lymphangiosarcoma, which is Stewart-Reeve syndrome, which might arise after a long time post-radiation with lymphatic blockage. So, option A is the answer here. Next is, if you read the question, if you read the image, what is the most probable diagnosis? A patient with abdominal pain, weight loss, sterile pyuria. The answer is, this is genitourinary TB with this kind. This is what is a classical Putty's kidney. So this is a Putty's kidney that you see in front of you, and option A is absolutely right. Next is, a 10-year-old boy skids while cycling, and this is prone to give a direct blow to the perineum. There is blood noted at the tip of the meatus. What is the next step? RGU, which is not there in the option. With that, SPC, suprapubic cystostomy, because you need to create a diversion. So option C is absolutely right. Now next is, a patient with breast lump diagnosed with invasive ductal cancer, which is ER positive, PR positive, HER2 negative, and now this could be either luminal A or luminal B. Now when we talk about luminal A versus B, if the Ki67 is more than 15%, it's a luminal B. Less than 15%, it's a luminal A. So this is where the Ki67 is 20 to 30. So it goes in the favor of luminal B. So luminal B. So the answer here is luminal B, because the Ki67 is 20 to 30. Next is, a lady complained of painful urge to defecate. Okay, without any stool. So there is proctitis because of the mucosal edema and because of some ulcer. With bloody diarrhea and increased frequency or rectal examination, there are no tags in perineal fistula. So what is the most probable diagnosis? It's a perineal disease, which is probably ulcerative colitis. And this is what is very, very, very important and common presentation. So what will you expect in our colonoscopy? Erythematous lesion with bleed on touch, skip areas, punched out lesion, ileocolic involvement. So when we talk about ulcerative colitis, what is the classical feature? Skip lesions, punched out ulcers, and ileocolic involvement is classical of Crohn's disease. In ulcerative colitis, what we get? Erythematous lesion with bleed on touch. So option A is the correct option. This is what is the most probable finding that you get to see on the colonoscopy. Next is, you see, what is this? This is perianal lesion, and what is this? This is fissure in ano. Now, when you talk about fissure in ano, the next thing is, let us see, which is not true. Proctoscopy should be done. This is never done. Why? Because it will aggravate the pain and aggravate the fissure also, and bleeding can start because it might tear off. High fiber diet, diltiazem, actually causes chemical sphincterotomy. It's a calcium channel blocker. And if it doesn't work, we'll go for lateral internal sphincterotomy. So option A is not true. The next is, a patient being treated for gallstone disease, an incidental tumor was detected in liver. It was resected and following thing is presented. So if you see, there is central stellate scar. So a liver tumor with a central stellate scar, what is this? This is FNH. Now let us read which of the following is correct. It is the most common benign tumor. No. Oncocytoma is the most commonly presents with rupture, bleeding or infarction. No. This is the feature of adenoma, hepatic adenoma. AFP is formed to be seen to be elevated. It might be seen in malignancy or in some you can say rapidly enlarging adenomas. Patient is, when you talk about FNH, they have the Kupffer cells also, and because of this Kupffer cells, the MRI SPIO scan, that is super permanganate iron oxide scan, is found to be positive, or we also say MRI sulfur scan will show you a hot bulb sign. So option B is absolutely true for this patient. Next is, a mother delivered a baby with unilateral cleft lip and palate, and she was worried about the feeding, which is not to be followed with this. Nasoalveolar molding is very important, and it is helpful in creating an adequate suction and thus helping in feeding. So this is true. Immediate surgery is not required. It is 3 to 6 months where we plan out surgery for soft palate, cleft lip, cleft palate accordingly. So this is also true. Direct breastfeeding is best option. This is absolutely false. We do a palatal feeding, we do a spoon or diya feeding, but a nasoalveolar molding, and along with that, the squeeze of the bottle should be synchronized with the suckling reflex, because they don't have a very strong reflex. So option C is absolutely wrong, and this is not to be followed. Now, patient presented to you with 0.5 centimeter of ulceroproliferative lesion involving the tongue, and the biopsy revealed SCC, USG neck, and CT scan revealed no enlarged lymph node. Now, this is actually very, you can say, common scenario where you don't have any enlarged lymph node, yet we are worried. Why? Because of the risk of occult metastasis, micrometastasis. And that is why nowadays it's a rule to go for SNLB. If SNLB is positive, then only we go for neck dissection. So prophylactic neck dissection is now getting replaced by sentinel lymph node biopsy. Next is you see a patient with breast and there is a cord-like structure under the breast and the diagnosis is Monders. So painful tender cord under the breast is due to superficial thrombophlebitis. So a vessel is involved, not vein. So Monders disease with lateral thoracic vein. So even if you did not know the name of the vein, so vein versus nerve, it is not nerve, it is vein. That is what is the answer, and option A is right. Next is a distal esophagectomy for Barrett's esophagus. Chest tube inserted to drain the fluid. A white milky appearance of the content of the drain was seen, and this is nothing but chylothorax. So chylothorax due to thoracic duct injury. So diagnosis can be confirmed by analyzing the lymphocyte count. Yes, and along with that, triglyceride levels are very important. Sometimes you might also give butter to the patient, and when the patient takes butter, the triglyceride level should jump. So more than 3 times increase is actually definitely proving that yes, it's a chylothorax. So wait and watch is what is the next management. We put the drain. Immediate surgical intervention not required. Chest drain should be removed, not required. It has to be there. The use of TPN is contraindicated. No, the TPN has to be given. That is what is very important. The next is a trauma patient brought to ER with motor vehicle accident and they're asking the GCS. So patient opens the eye to pain. So that is 2. Incomprehensible speech. So V is 2. And decerebrator extensor posturing. So M is 3 basically. M is 3. So 3 plus 2 plus 2, that is 7. So 7 by 15 is what is the GCS. This is what is B. B is the answer here. Next is, I'll not read the question, which is the most likely responsible condition for this. This is a plano-convex condition or concavo-convex, and this is SDH. So just by seeing the question, reading the last line of the question and reading the options, you can straightforward save a lot of time. Which of the following is a potential complication of surgical site infection? So whenever there is a wound, the first thing that will happen, that is delayed wound healing. So this is what is very important. Until unless the SSI goes systemic grossly and patient enters into shock, you'll not have all these things like renal failure. So option D is the most potential answer in this case. Next is a 45-year-old with trauma now develops dyspnea, tachycardia, hypotension. So tachycardia, hypotension. The examination reveals muffled heart sounds, elevated JVP. You know that we are talking about the Beck stride in case of cardiac tamponade. A chest X-ray shown. What is the next? USG guided needle pericardiocentesis, and this is what is very important. If the patient improves with this, so you'll go for observation. If the patient worsens with this, you have to go for pericardiomyotomy and ligate the bleeding vessel. So option A is far better than option B. This is what is very important. Next is 32-year-old woman planned for surgery due to toxic adenoma. Post-operative day 3, she develops muscle cramp, paresthesia and tingling. So we are talking about hypocalcemia, and this is because of the ipsilateral loss of the parathyroid gland. So what is the next thing? You will check for the signs of hypocalcemia. True use is present. Lab shows the calcium level less than 8. Now less than 8 is an alarming, where the patient can have cardiac arrest any point of time. So you need to go for IV calcium gluconate, and along with that, the calcium oral supplementation has to be started. So IV calcium gluconate is what is required, and then once the patient is stable, so A is far better option than D, or you can say A followed by D is the next line of management. Next is a patient with limb edema. This is relieved by standing or limb elevation or sitting. On our examination, there is corona phlebectasia. Now, when we talk about corona phlebectasia, they are nothing but the skin sign changes. So, C4A includes only pigmentation. C4B is lipodermatosclerosis, and C4C is corona phlebectasia. So option here is C4C. C5 is related to ulcer, and a healed ulcer is C5, and non-healing ulcer is C6. Next is, I am just seeing the image. Which of the following statement is not true? So if you can see, this is a case of hypospadiasis. So when we talk about hypospadiasis, which of the following is not true? It's the most common congenital anomaly. Absolutely true. The diagnosis is made just by looking. Yes, absolutely true. You need to see cordy, hooded penis. This is what is very important. Surgery should be done after 3 years. No, you can say the orthoplasty, the curvature correction is started between 6 to 12 months, and granuloplasty can be deferred as long as up to the puberty also. Disorders of sexual development, this is because of the defective tubularization of the urethral plate, which may be due to defective androgens or androgen receptor. That is why sexual development disorders should be ruled out in this case. The next is you see a patient with CA penis. When you talk about CA penis, following is the cause of the death. Now, how will this patient die? Either with a metastatic, you can say spread causing organ failure. Now, in relevance to this image, this tumor might infiltrate into the iliacs or the suppurative lymph nodes, or you can say tumor infested lymph nodes might invade into the iliacs. So erosion of the external iliac vessel is the most common cause and the deadly, you can say, cause of the, you can say, death in these patients, sudden death in these patients. So option A is absolutely right. So I hope you enjoyed these you can say solutions. So best of luck for your exam.
Hello and welcome to the another session of Grand Test. Hello and welcome to the another session of Grand Test, and we are here to discuss the questions related to orthopedics. The first question, obviously, that which of the following is false regarding the X-ray findings of scurvy. You know, the importance of this question is that as far as the topic scurvy is concerned, only 3 points you need to remember. The point number 1 is the importance of vitamin C deficiency. All of you are aware that vitamin C is actually acting as a cofactor for hydroxylase enzyme, and that is the importance, that is the requirement for the maturation of the type 1 collagen. You know, bone collagen is type 1 majority of the times, and this type 1 collagen has got integrated lysine and proline in the form of its hydroxy forms. Like the lysine has to be converted into hydroxylysine. Similarly, the proline has to be converted into hydroxyproline. Then only the matured type 1 collagen would be created. For this hydroxylation, the name of the enzyme which is required is hydroxylase enzyme. And this hydroxylase enzyme requires vitamin C as a cofactor. Now, if vitamin C is deficient, obviously this conversion of proline into hydroxyproline and lysine into hydroxylysine would be affected, as a result of which the type 1 collagen which is being created would be of defective form. So, thereby the consequences. So, that is point number 1 that you have to remember about scurvy. Point number 2, always remember, related to scurvy are the X-ray findings. Now, what all are important X-ray findings related to scurvy are that there is increased density of the margins of the epiphysis. You know, these are the margins of the epiphysis and they are sclerosed. They are having increased density in comparison to the bony matrix of the epiphysis. Now, this sign is known as ring sign of Wimberger. Ring sign of Wimberger. So, these are the X-ray finding related to scurvy. That is X-ray sign number 1. Now, X-ray sign number 2 is that you can very easily understand or realize that this metaphyseal end of the bone, this region, the metaphyseal end of the bone, which is the zone of provisional calcification, it is more dense in comparison to the other densities of the bone or the surrounding densities of the bone. And this increased density of the zone of provisional calcification in the adjacent to the metaphysis is known as Frankel line. So, this is Frankel line, another X-ray finding of importance for it to be identified. The third one is, then you can clearly identify that there is a projection at the end of the bones. Now, these are hyper projected, the conical hyper projections of the end of the metaphysis, and these hyper projections are known by the name of Pelkan spur. And finally, you know, adjacent to this zone of provisional calcification, the metaphyseal end is having a relatively radiolucent zone. The zone of radiolucency. You can very clearly identify this zone of radiolucency, and this is referred to as the Trümmerfeld zone. So, this is Trümmerfeld zone. All right. So basically what we have discussed related to scurvy, point number 1 was the importance of vitamin C in the procurement of the type 1 collagen. And the second importance is that of the identification of the X-ray findings on the scurvy. You know, X-rays of the knee joint, if are provided asking for a metabolic abnormality, then probably the examiner this time is asking about the scurvy X-ray findings. So this is how you are going to relate it with. The third point related to scurvy that you have to remember is that, you know, this white line of Frankel, don't get confused, this white line of Frankel is actually this, we have discussed the Frankel's line. This white line of Frankel is actually a feature of scurvy. It is never a feature of rickets, right? Although the sign of a healing ricket is also increased in the density of the zone of the provisional calcification, but that is not given a term as white line of Frankel. White line of Frankel is a feature of scurvy, identifiable feature of scurvy. So these are the findings that you have to remember related to scurvy. These are the 3 points that you have to remember related to scurvy. Now, if you go back to the question now it will become much easier for us to understand and handle this question in particular, that which of the following is false about the X-ray findings of scurvy. Point number 1, a dense line between metaphysis and the epiphyseal cartilage, as we have very clearly identified that in between the epiphysis and metaphysis there is a growth plate. One of the zone of the growth plate is the zone of provisional calcification. This zone of provisional calcification is more calcified, more dense in comparison to the other ones, and this is white line of Frankel, which we have already discussed. So this option is obviously correct. Next, a bone spur from the lateral border of the metaphysis, which is Pelkin spur, which is also a feature, identifiable feature for the scurvy. So this option is also true. Next, increase in the density of the ring epiphysis around the epiphysis. This is ring sign of Wimberger. So this is also true. So first 3 options are actually the signs for the scurvy on the X-rays. So obviously what we are left with is the pelvic brim sign. You know, this pelvic brim sign is actually the answer for this question, but also you should be aware of what actually is the pelvic brim sign. Now, if you identify in this X-ray that, you know, this is the iliopectineal line, this one, and the other one is ilioischial line. So here there is an increase in the density of the iliopectineal line. So this is increased density of the iliopectineal line. Alright, and this is a feature of Paget disease. It is never a feature of scurvy. This is the feature of osteitis deformans. So this is a feature of Paget disease. Alright, so hopefully everything is clear related to this particular question. This increase in the density of the iliopectineal line is a feature of Paget disease. Alright, so again I am repeating 3 points you need to remember about scurvy is the role of vitamin C, the X-ray findings, and the white line of Frankel. Don't get confused. It is never a feature of rickets. Although it is similar to what we find in case of healing ricket, but this white line of Frankel is the term which is coined for scurvy identification. Hopefully everything is clear. Next, come to the next question. After falling from an outstretched hand, a 55-year-old woman, that means an elderly woman, present in the emergency with the pain and swelling in her wrist. You know, whenever you get this kind of a question, particularly in the FMGE examination, that where there is a elderly female who is having injury around the wrist joint, then possibly the examiner is asking about the Colles fracture. Alright, this is the most important hint which will be ever provided to you in the question related to this particular topic. Now, before confirming the diagnosis, let's read the entire question. Now, upon physical examination, the wrist has a noticeable deformity, and we already know what the deformity is. It is a dinner fork deformity, and the reason for the dinner fork deformity is that, you know, if there is a fracture of the distal end of the radius where there is a dorsal subluxation or dorsal displacement of the distal fragment leading to the step kind of a deformity at the proximal end of the or the dorsal surface of the forearm, this is known by the name of dinner fork deformity in case of Colles, which is easily identifiable. Okay, so already we have presumably made the diagnosis, then possibly the examiner is asking about the Colles fracture, but there are several other things which are provided in the question, and let's read the entire question before jumping to the diagnosis. Now, anatomical snuff box is painful. Now, this thing can confuse you that anatomical snuff box is painful because it happens in case of Colles fracture, it can happen in case of radial styloid fracture. It can happen in case of the Schaufer's fracture. It can happen in case of a scaphoid fracture. So, there are majority of the fractures around the wrist joint on the lateral aspect might present with the anatomical snuff box tenderness. Okay. Now, X-ray reveals the fracture of the distal radius with the dorsal angulation and impaction. And in Colles fracture, we have hundreds of the times discussed that the displacement in the Colles fracture, which is a defining displacement for the Colles fracture, is the dorsal subluxation. That means dorsal displacement. Now, this dorsal displacement could be a dorsal tilt, it could be a dorsal shift, it could be a dorsal angulation, and there is an impaction also. There is attrition of the fragments also. So, this is confirming your diagnosis, because everything which is required to make the diagnosis for Colles fracture is provided to you in the question. Now, answer for this particular question is Colles. Now, if you look at this other options like why not Smith fracture? Why not Smith fracture is the answer for this question, because in Smith fracture, there has to be a ventral subluxation. Alright, there has to be a ventral displacement in case of Smith fracture. The same fracture, but with a ventral displacement, it would be called as Smith, that is reverse Colles. Now, why is it not Barton's fracture? Because Barton's fracture is the intra-articular fracture of the distal radius. It would be intra-articular fracture of the distal radius with variable presentations. So, this has to be provided to you in the question if the examiner is seeking for the answer of Barton's fracture. And finally, the Schaffer's fracture. The Schaffer's fracture is the fracture of the radial styloid. It is the fracture of the radial styloid. Now, only thing that goes in the favor of the fracture of the radial styloid is the anatomical snuff box tenderness. But rest everything else is going in the favor of the Colles fracture. So, the best possible answer for this particular question is Colles fracture. Very commonly asked question. Every time you sit in the examination, at least one question out of this Colles topic will be there for you to assess. Alright. Next question is a 65-year-old female. Alright, so age is provided to you, brought to the emergency department after a fall at home. Now, this is very common as a phenomena because, getting slipped in the washroom, getting slipped while running down the stairs is a very common phenomena that is encountered in this age group. Now, she complains of severe pain in her left hip and cannot bear the weight on the affected leg. Obviously, there is a significant injury that has happened in the proximal aspect of the femur in particular. Now, X-rays are as follows. Now, they are providing you the X-rays and then they are asking what is the likely attitude of the patient that the patient could be presenting with. Now, there are two forms out of this which you can make out of this question. One is identify the abnormality, and on the basis of that identification, whatever you have learned about that abnormality, you mark the answer for that question. But how to assess for the attitude is by the provision of the X-rays. That means you read the X-ray first, and whatever you can make out of that X-ray, that will be the attitude for that patient. Now, just try to understand how these X-rays are being read. Now, first of all, this is the right hip and this is the left hip. As it is very clearly evident that the right hip is normal and the left sided is abnormal. That means there is an abnormality in the left lower limb. Now, in the left hip, as you can very clearly identify that the patient is suffering from, the patient is having a fracture in the neck of femur. Alright, there is a fracture in the neck of femur region, which is very clearly identified. This region is fractured. So, here there is a fracture in the neck of femur. Now, if you compare the two lines which are provided to you in the X-ray, like this is the level of the greater trochanter on the right side, this is the level of the greater trochanter on the left side. And as you can very clearly see that the tip of the greater trochanter on the left side is higher in comparison to the normal one. That means there is a suitable amount of, or there is a possible shortening that the patient could be presenting with. So, one thing in the form of the attitude, just by reading the X-ray, is whether it is lengthened or shortened. So, one thing that you can frame out is that there is a shortening of the limb. That is point number one. Alright. Now, point number two is that whether the limb is in adduction or abduction on the basis of the X-rays, whether the limb is in adduction or abduction. Now, if you look at the axis of the femur, this is the axis of the femur, which is absolutely lying perpendicular to the axis of the pelvis. That means it is creating almost an angle of 90 degrees, which is considered to be a neutral position. But if you look at the axis of the femur on the other side, so we can very clearly identify that the limb has moved slightly away from the midline of the body. That means it has moved into abduction. So, one of the critical findings that you can make out from the X-ray is the shortening, and the other one is the abduction. So, the second thing that you can make out from this X-ray in particular is the abduction. Now, third possibility is that of a rotation. That means whether it has moved into internal or a external kind of a rotation. Now, in order to identify these rotational abnormalities, you have to look at this lesser trochanter. You know, this is how the normal neutral positioned lesser trochanter looks like in 10 degrees of external rotation. But if the limb is more externally rotated, then there will be more pronounced lesser trochanter. You can very clearly identify in between the two that the lesser trochanter on the left side is more pronounced, it is more visible in comparison to that of the right side. And this is how you will identify that the limb has moved into external rotation. Now imagine if the abnormality or if the visualization of this lesser trochanter is lesser in comparison to the normal, it means that the limb has moved into internal rotation. So this is how you will decide, because there is no other way to identify whether the limb has moved into internal or external rotation. Only the lesser trochanter you have to see. If the lesser trochanter is more visible in comparison to the normal one, if it is more pronounced in visibility, that means the limb is in external rotation. If the lesser trochanter is less visible in comparison to the normal, all right, it is hidden, then it is the limb in internal rotation. So here the limb is in external rotation. All right. So if I say, like in the beginning of this question, I told you that there are two ways in framing out the answer. The first way is identify the fracture neck of femur and the attitude that you might have learned, that how the patient presents with the fracture neck of femur. On the basis of that, you will mark the answer. But you know, this is not the correct way of answering the question. Why? Because there is a variable presentation. Some of the fracture neck of femur patient might come with the flexion. Some of the fracture neck of femur might come with the internally rotated limb. But majority of them, it comes with the externally rotated and abducted limb. Alright. So what is the best possible answer out of this particular question? It is external rotation, abduction and shortening of the limb. Hopefully you have identified the way how to proceed with these kind of the question based on the readings of the X-rays. The three things that you have learned out of this particular reading of the X-ray is that how to determine the shortening, how to look out for the shortening is by leveling of the greater trochanter. Second is how to look for the abduction or the adduction abnormality is by looking at the axis of the femur. Third thing is how to look out for the internal and external rotation of the hip joint by looking at the lesser trochanter. Alright, so this is how you will proceed with this question, and that is the particular answer for this question. Next question is 12-year-old boy complain of progressive worsening pain and swelling in the right tibia. Alright, the pain is more severe at night and gets better with the rest. So more pain at night, whenever you find these kind of the features that the patient is having more pain at night, alright, that there is a diurnal variation as far as this pain is concerned, then the pathology is more likely going towards the infective side. Now, physical examination shows tenderness and a noticeable mass in the affected area. X-ray reveals a well-defined lytic lesion with sclerotic borders in the metaphysis of the tibia. What is the most likely diagnosis? So, basically, you know, whenever we are having, imagine this is the proximal end of the tibia the patient is having. And here they are talking about a lytic lesion with a well-defined sclerosed margins, alright, within the proximal region of the tibia, then possibly with a noticeable mass, that means there is a outpouching to some extent, then possibly it is a kind of the abscess which is well contained within the lesion, alright, a kind of the abscess which is well contained within the lesion. And possible answer for this particular question is the Brody's abscess. You know, why is it not osteosarcoma? Because in case of osteosarcomatous lesion, it is not a lytic lesion. Alright, osteosarcomatous lesions are the calcified lesion. They are growing out of the capsule. The mass is not only located at the site of the origin. There is going to be the encroachment of the soft tissues or all the components of the extracapsular region. And as far as X-ray findings are concerned, there has to be a calcification, there has to be a sunburst appearance, there has to be a periosteal reaction. As far as Ewing sarcoma is concerned, there has to be a diaphyseal involvement, there has to be a swelling in the midline region of the bone, there has to be a periosteal elevation reaction in the form of the onion peel appearance, and that is not a gradually progressive kind of a condition. It is a severe condition that has to be, it is a malignant kind of the tumor. That presentation varies from age group to age group. Then comes the osteomyelitis. Now, osteomyelitis related clinical picture would be more severe, like the patient is going to have more fever, the patient will be developing these kind of features very acutely within a short span of time. There has to be a massive swelling, all right, and the patient won't be able to use the limb. So the pain will persist throughout. There will be a gradually progressive pain. It is not going to have a diurnal kind of a variation. So best possible answer for this particular question is the Brody's abscess. Next, the Dunlop traction is used. There are several named traction that you should be aware of. Now, all these kind of the tractions are today, they are obsolete, but because they were named traction, so there is always a possibility that the examiner might give you these kind of the questions in your examination. All right. Dunlop traction is used for the fractures around the elbow. That means supracondylar fractures in case of humerus. Because today we are not talking about the fracture fixation or fracture management by putting the patient on traction. We are fixing it immediately by using the percutaneous K wires or by provision of the slab, if at all the supracondylar fractures are not displaced. So Dunlop traction is used for supracondylar fractures of the humerus. And you know that these supracondylar fracture of the humerus more commonly are happening in case of children. Then if you look at the other options like cervical spine injuries, for that we are providing the Holter traction. Holter traction is given for cervical spine injuries, although there are several like Crutchfield tongs can also be provided for cervical traction. Stability is provided by the provision of the Philadelphia collar in case of cervical injuries, and Holter traction can also be provided. So the name of the traction system which is used in case of cervical injuries is the Holter traction. As far as for trochanteric fracture are concerned, the name of the traction system is Hamilton-Russell traction. Hamilton-Russell traction system is used in case of trochanteric fractures. That means fractures around the greater trochanter, lesser trochanter, intertrochanteric region, subtrochanteric region. So these are the regions where Russell traction could be used. Supracondylar fractures of the humerus we have just talked about. This Dunlop traction is used for this purpose. And fracture shaft of the femur in case of a child, the name of the traction system is Gallows traction. All right. The name of the traction system is Gallows traction. In case of children, fracture shaft of the femur in case of a child, in case of a newborn, in case of a infant, Gallows traction is used for that purpose. So these are the name traction system that you should be aware of. All right. Hopefully the session and its explanation was helpful in your preparation.
Hi, I hope you had a very good grand test. So let us discuss what were the questions asked from anesthesia and emergency medicine. So first question was image-based question. The image was given and it was asked what is the maneuver shown. So as I told you, there are two maneuvers to open an airway. One of them is asked in this image. This from one hand the victim's head is pushed backward and with the other hand chin is lifted upward. So this is head tilt, chin lift. Okay. So both the hand of the rescuer is doing two different things. One hand is pushing the head backward and other is lifting the chin forward. So it's head tilt, chin lift. Okay. The second question which was asked on CPR, a 45-year-old male collapses suddenly in public place. You are nearby and quickly responding to the situation. So you are the rescuer. What is the correct sequence? So what did I tell you? The BLS sequence. So BLS sequence has been asked. So it is in the public space. The first thing we have to ensure is scene safety. After ensuring the scene safety, we have to call for help because we have an unresponsive person with us. Okay. So scene safety, the person's response is checked, unresponsive, we call for help. Then we check the pulse and breathing and then accordingly we intervene. So what were the options? First option, assess the safety of the surrounding. Determine the patient's response, activate emergency response system, ERS, check carotid pulse, begin CPR. Well, this seems a correct sequence. So I would certainly go for this as an answer. The second sequence, same, only the scene safety has not been added. Well, you are in the public space. There can be more of people. First, we have to see the scene is safe or not, right? So scene safety is the first priority which we have to do. Otherwise, the victim and the rescuer both can become unsafe, okay? So A is the answer, okay? Third, a 35-year-old male with palpitation and dizziness was brought to ER emergency. On examination, his pulse rate was 180 beats per minute. His blood pressure was 110/80 and patient was hemodynamically stable and ECG is like this, okay? So this ECG, is pulse rate is 180 beats per minute. So patient has tachycardia. As we can see, no P wave. P wave is hidden in the CCG, or it's not. We are not able to distinguish whether it's P wave or T wave, right? This is your supraventricular tachyarrhythmia. Supraventricular tachyarrhythmia, as then QRS complex is narrow. Supraventricular tachyarrhythmia because QRS complex is narrow, right? So we have a patient with supraventricular tachyarrhythmia but hemodynamically stable. So in stable tachyarrhythmia, we have to manage. If this would have been unstable tachyarrhythmia, the answer would have been cardioversion. Immediately we have to cardiovert, but the patient is hemodynamically stable. So we will manage by drugs and interventions. So supraventricular tachyarrhythmia, the first thing which we do, vagal maneuver, right? So answer would be vagal maneuver. If 25% of the patient responds to vagal maneuver, right, what we do carotid sinus massage, one side at a time. If the vagal maneuver fails, then we go for adenosine, 6 milligram the first dose, and then we can repeat the second dose with double, that is 12 milligram. So this is done in a sequence. In supraventricular tachyarrhythmia, vagal maneuver followed by adenosine 6 milligram followed by adenosine 12 milligram. Got it? And if the patient would have been unstable, then we could have gone for electric cardioversion. Got my point? So answer is vagal maneuver. Fourth question, the correct arrangement of inhalation according to potency, highest to lowest. So what tell us about the potency? The MAC tell us about the potency. We know MAC is minimum alveolar concentration. High MAC, less potency. High MAC, low potency, right? Okay. Low MAC, high potency, the vice versa. The highest MAC we have nitrous oxide. Nitrous oxide MAC is 104. I told you. Nitrous oxide is least potent and the most potent is methoxyfluorine. Okay, methoxyfluorine. So methoxy and nitrous oxide are on the two extremes. Methoxy most potent, nitrous oxide least potent. And in between, according to the sequence, the agent came in the clinical practice, which I told you. Halothane, isoflurane, sevoflurane, and desflurane. So we'll try to find the sequence. Okay. And xenon, another carrier gas, is more potent than nitrous oxide. So xenon is more potent than nitrous oxide. Right, definitely it's the carrier gas, so less potent than other potent anesthetic agent. So let us find the sequence. Nitrous oxide is not at all highest potent, it is least potent. So let us see the sequences with nitrous oxide at the end. Okay, so we have two sequences with nitrous oxide at the end. Now, halothane, isoflurane, sevoflurane, desflurane, xenon, the first C option. This seems correct. Halothane, sevoflurane, desflurane, isoflurane, wrong option. Isoflurane is more potent than sevo and desflurane. The sequence we have to follow. Halo came first, it is most potent. Then iso, then sevo, and then des. Then xenon, and then nitrous oxide. And overall most potent is methoxyfluorine. Got it? So answer is C. Then fifth, the last question which was asked. An infant was playing with marbles in a courtyard. He suddenly becomes listless. So he becomes unresponsive and he was playing with marble. Definitely may have, let's say, ingested the marble and it may have gone into his respiratory tract. To assess the cardiac arrest, so he has become listless, unresponsive. So we have to see whether the patient is in cardiac arrest or not. To assess the cardiac arrest, which pulse would be assessed in this patient? It's infant. So in infant, I told you, we always assess the brachial pulse. So infant, which pulse is assessed? It is brachial. If it is child, right, then we go for either carotid or femoral, right, carotid or femoral. And if it's adult, we always go for carotid, no other pulse. Got it? So these are the pulse which is assessed to assess whether the patient is in cardiac arrest or not. So these were the 5 simple questions. I hope you have done all the questions correct. Thank you.
Hello friends, I am Dr. Harmeet Goel, Obs Gynae faculty, and I am discussing the Grand Test 9 July Obs Gynae questions. So let us start, okay? Are you all there? Okay. Keep on writing your answers in the chat box, okay? So first question is, 27-year-old primary gravida at 36 weeks was admitted to the obstetrics ward in view of pain abdomen, mainly the right hypochondrium. Okay. So pain abdomen, primary gravida patient, and she has pain in the epigastrium and she has nausea, vomiting. So that means she has GI symptoms and her blood pressure is 170 by 120. So pregnant lady with a high blood pressure, this is preeclampsia. But if the blood pressure is more than 160 by 110, this is severe preeclampsia with nausea, vomiting, with epigastric pain. So friends, when there is a clinical presentation of the questions and the pattern is going to be clinical, but you should revise everything, okay? Image based questions, single liners, concept based questions, even the previous year's questions as well as the clinical presentation. So you get your answers when you short down the clinical questions. So the investigations all were sent which showed platelets decreased, liver enzymes elevated, bilirubin elevated. Which of the following is false regarding the diagnosis? So keep on writing your answers in the chat box. Management of this syndrome is immediate termination of pregnancy following careful examination of the fetal and maternal status. Yes, whenever there is severe preeclampsia with warning symptoms or with HELP syndrome, hemolysis, elevated liver enzymes and low platelets, you should terminate the pregnancy. So the statement number A is correct. Let us see the second, third and fourth options. This syndrome cannot manifest in the absence of maternal hypertension. This syndrome requires platelet transfusion when platelet count is less than 50,000. The most common mode of delivery is cesarean section using epidural analgesia is safe if the platelet is greater than 1 lakh per cubic millimeter. Let me tell you, HELP syndrome can occur even without preeclampsia. Okay. So this is a wrong answer. So answer to this question is statement number B. So let me tell you, from this history which has given to me and the investigation, it appears that this is HELP syndrome. Okay. HELP syndrome occurs in 10 to 15% cases of severe preeclampsia. ठीक है. HELP syndrome, you know, hemolysis that you check on peripheral smear, then there is elevated liver enzymes and then there is low platelets. ठीक है. Platelets less than 40,000 per cubic millimeters. Normal is 1.5 to 4 lakh per cubic millimeters. Liver enzymes are elevated, especially the LDH is more than 500 or 600 international units per liter. Peripheral smear shows hemolysis. Okay. So this is HELP syndrome. Okay. Ultrasound abdomen or CT scan should be done for the diagnosis and it shows subcapsular hematoma. In rare cases, there can be liver rupture. Okay. So here the management, after you manage the platelet transfusion, if the platelets is going down, management is always termination of pregnancy. Now you have to here give the antihypertensive and you have to give magnesium sulfate because she has already developed the warning symptom, that is epigastric pain, and the blood investigations have been deranged. Okay, so she can throw fits also. So to prevent the fits, you have to add the magnesium sulfate. So magnesium sulfate is a drug to be given for severe preeclampsia to prevent convulsions, and antihypertensive you have to add it to reduce the blood pressure and simultaneously conduct the delivery. So epidural anesthesia is the safe anesthesia, and you perform a cesarean section if the cervix is closed. Clear? Next, a 40-year-old multigravida with 12 weeks history of amenorrhea. Amenorrhea is 3 months, and she presents to the obstetrics OPD with chief complaints of bleeding per vaginum. So she has amenorrhea of 12 weeks. She has amenorrhea of 12 weeks. She has bleeding per vaginum. She has pain abdomen, and there is multiple episodes of bleeding. On examination, uterus is more than the period of gestation. Fundal height is more than the period of gestation, and no fetal parts palpable. So which of the following is true regarding the diagnosis and the management? So friends, amenorrhea, pain abdomen, bleeding, vomiting, per abdomen, fundal height more than the period of gestation, and no fetal parts palpable. No fetal parts palpable. And if you try to do the Doppler, even you will not be able to auscultate the fetal heart. So it gives a soft and duffy feeling. So this goes in favor of H molar pregnancy. And since what do you find in the ultrasound? Investigation of choice for diagnosis of H molar pregnancy is ultrasound. And what do you see? You see snowstorm appearance. Snowstorm appearance. And the management, if it is young female, then the management is suction, evacuation, followed by curettage. Okay? And if the age of the patient is above 40 years, her family is complete, and she belongs to high risk case, in that case your management is hysterectomy, keeping the H mole in situ. So let us see what is written in the question. Age of the female is 40, she is multiparous, she has 3 months, amenorrhea, pain, bleeding, vomiting, uterus more than the fundal height, no fetal parts palpable. So this is H molar pregnancy, and I am going to do hysterectomy in this case because she is multiparous, she is above 40 years, so she belongs to high risk case. So management will be hysterectomy. Now next question, a pregnant woman. I hope it's clear to all of you. So keep on writing in the chat box. Keep on writing your answers in the chat box. Dr. Anil, Dr. Paras, Dr. Soni, Dr. Shivangi Tiwari. So you can keep on writing your answers in the chat box. A pregnant woman at 16 weeks of comes for an antenatal checkup, where on examination obstetrician finds an fundal height of the uterus 20. That means fundal height is more than the period of gestation, and ultrasound was done and it showed it is polyhydramnios. So when the fundal height is more than the period of gestation, the first differential diagnosis is wrong dates. If your patient says she is very sure of the dates, then you do the palpation, the fundal height examination, the presentation of the fetal parts, etc. has to be done. So in this case, the ultrasound finding has showed polyhydramnios. Ultrasound finding has showed polyhydramnios. Okay. So which of the following is most likely cause for this polyhydramnios? So during pregnancy, baby keeps on secreting the liquor and baby keeps on drinking the liquor. Welcome Dr. Prateek, Dr. Dog, Dr. Shivanging, Dr. Anil, Dr. Soni, Dr. Paras, Dr. Patel. All of you are welcome to this session. So keep on writing your answers in the chat box. So whenever there is more production of the amniotic fluid, that is open neural tube defects, tracheoesophageal fistula, esophageal atresia, or there is defect in the swallowing, or there can be maternal diabetes, or there can be placental causes. All of them are responsible for polyhydramnios. So placental insufficiency will call oligo, renal agenesis will call oligo, and IUGR will cause oligohydramnios. So A, B, D will cause oligohydramnios, and answer to this question is maternal diabetes. Okay. So the correct answer is C, that is maternal diabetes. Okay. So welcome Dr. Surbhi. So polyhydramnios. First of all, let me tell you the normal values of amniotic fluid, okay, on ultrasound. If amniotic fluid index normal is between 5 to 24 centimeters, this I am quoting the textbook Williams Obstetrics, okay, or there is single deepest amniotic fluid pocket, vertical diameter more than normal, let me tell you, normal is 2 to 8 centimeters. Okay. Now, when do you call it as polyhydramnios? When amniotic fluid is more than 2 liters or amniotic fluid index is more than 25 centimeters or liquor pocket is more than 8 centimeters, we call it as polyhydramnios. So the causes for polyhydramnios is fetal congenital anomalies like neural tube defects, open neural tube defects, anencephaly, tracheoesophageal fistula, esophageal atresia. In the maternal it is diabetes. So when there is diabetes, that increased glucose is going to the baby, and there is diuresis. So baby is producing more urination. Fine. So in that case, the liquor will increase. So you are supposed to remember the normal amniotic fluid index and single deepest liquor pocket and the values of polyhydramnios. So all of you are writing the correct answer. So answer is C. All of you are right. Fine. Now next question. It is going to be a very crisp revision from my side, because all of you have been doing very well in my previous sessions, whether it is high yield questions, whether it is recall questions, whether it is taking a class, whether it is doing a revision for your exam. So all of you are doing wonderful. So quick and crisp revision of today's session. Okay. Not very details, because details I had already been teaching plenty of times. Fine. About cardiovascular changes in pregnancy, which of the following is false? Okay. Beginning in the 5th week of pregnancy, cardiac output reaches peak at 30 to 34 weeks of pregnancy, 40 to 50%, correct. Progesterone, nitrous oxide, prostaglandins have smooth muscle relaxing effect, which causes relaxation of smooth muscle. So peripheral vascular resistance falls, yes, which is the hormone that normally maintains pregnancy is the progesterone. So this is correct. Apex beat is shifted towards mid clavicular line. This is also correct. but systolic murmur greater than 3 is normal, that is wrong. So if any systolic murmur is there, okay, it should be either grade 1 or grade 2, that is normal. If it is more than or equal to grade 3, that is abnormal and we consider it a heart disease. Okay, presence of diastolic murmur, cardiomegaly, systolic murmur more than grade 3, okay, split S2, all these are the features of abnormality. Okay, so here the wrong answer is systolic murmur greater than grade 3, which is not normal, it is abnormal and it is suggestive of cardiac disease. Now, during her annual gynecological examination, a patient who works as a ward attendant in the surgical intensive care unit at nearby community hospital visits you. She informs you that she wants to stop oral contraceptive pills because she is trying to get pregnant in next few months. So she has been on psychiatric medication. Okay, this patient is quite concerned about potential negative outcome of the anti-epileptic drugs. Which of the following drug is absolutely contraindicated in pregnancy? I have already taught you plenty of times in my revision classes and live classes, face-to-face sessions, that the anti-epileptic drug which is absolutely contraindicated is sodium valproate because it has got teratogenic effect. It has got teratogenic effect. Okay, so sodium valproate is causing the teratogenicity, but other drugs also cause teratogenic effects. But looking at the pros and cons and looking at the value of anti-epileptic drug, I am not going to stop all the B, C and D drugs that can be given. Okay, now what is the anti-epileptic drug of choice in pregnancy? Anti-epileptic drug of choice in pregnancy, answer is levetiracetam. Levetiracetam, then if that's not given in the answer, then answer is lamotrigine. Okay, so anti-epileptic drug with least teratogenic effect is levetiracetam. Maximum teratogenic effect is sodium valproate. Okay, otherwise other drugs like lithium, it can cause abstinence anomaly. Phenytoin is also contraindicated in first trimester. It can be given safely in the second and third trimester. So here the answer is sodium valproate. Now, anti-epileptic, when you are giving to the patient, which vitamin deficiency occurs? Answer is folic acid deficiency occurs with anti-epileptic drugs. Next, all of the following are diagnostic criteria for preterm labor pains except preterm labor pains means labor pains are starting before 37 weeks of pregnancy. Okay, so that is preterm labor pains. And what do you do when you want to arrest the preterm labor pains? You use tocolytic agents, and the best, safest tocolytic agent, best, safest in or drug of choice for tocolysis is nifedipine. Drug of choice for tocolysis is nifedipine. Okay, other tocolytic agents are beta adrenergic drugs, or there can be magnesium sulfate, but we prefer nifedipine because it is safest. Now my question is, which of the following is not a diagnostic criteria for preterm labor pains? 4 contractions in 20 minutes and 8 contractions in 60 minutes. This is correct. It is preterm labor pains. Cervical dilatation more than 2 cm, that is also included in the criteria. Effacement more than 80%, that is also included. Cervix is posterior, this is no criteria. So wrong answer is D. Cervix, whether anterior or posterior, hardly going to make any difference. Okay, that is what is called as position of the cervix. So contractions are occurring, cervical dilatation is occurring, there is effacement that is occurring. So we say it is preterm labor pains. What additional injection you are supposed to give? You are supposed to give tocolytic agents if she is not in active labor. You are going to do bed rest. You are going to send the investigations, and in this case, you basically have to give steroid injections also. Steroid injections to cause fetal lung maturity. Fetal lung maturity. Fine. Because if you are not able to arrest the preterm labor pains, she is gone into active labor, you cannot arrest the preterm labor pains. So there we are just concerned about the lung maturity of the baby. Okay, so we give steroids to the pregnant lady and that can cause lung maturity in the baby. So, but for steroids to act and work and cause lung maturity, it requires at least 24 hours. Fine. Now, next question. You are asked to counsel a woman who is planning to have another baby after her first baby born with spina bifida. You explain to her neural tube defects have multifactorial etiology. One of the main factors is folic acid deficiency. Yes, true. We always advise her to take the preconceptional folic acid, that is therapeutic. The tablet available is 5 milligram, but the recommended dose is 4 milligram. 2 months before planning the pregnancy, and she should continue the therapeutic folic acid during the organogenesis period, that is for the first trimester of pregnancy. After that, she should switch over to iron folic acid combination and calcium supplementation. So let us see, in the preconceptional supplementation is recommended for all pregnant ladies to reduce incidence of neural tube defects. What is true of all of the following except? All neural tube defects are preventable by preconceptional folic acid? No. In the question, it's already written the etiology is multifactorial. So how can just giving folic acid one small tablet, it is going to prevent all the neural tube defects that can occur? No, because the etiology of the neural tube defects is multifactorial. So giving just folic acid will not work, although we always give folic acid before she is planning the pregnancy. Now, in a woman prior affected fetus, the risk of recurrence is high with a reduced. Okay, so when you are giving folic acid, the risk is reduced to 70%. This is correct statement. Anti-epileptic drug increases the chances for neural tube defects by interfering with folic acid metabolism. This is also correct. In a woman with no history of neural tube defects, routine folic acid supplementation dosage is 400 microgram. This is also correct statement. So all neural tube defects cannot be prevented by just giving folic acid. Okay. Now, therapeutic folic acid. Therapeutic folic acid should be given 2 months before conception. That is called as preconception period. Preconception period, and she should continue for the first 3 months of pregnancy. Okay. So what is the dose is 4 milligram, that is 4000 micrograms. She should take it daily. Now after the 12 weeks are over, okay, then she is supposed to give iron plus folic acid. Okay, iron is 60 milligram of elemental iron and folic acid is 400 microgram, but the tablet available is 500 microgram. So she should give in the second trimester, third trimester and in the lactation phase. Okay, and then calcium also has to be added 1 gram daily. Okay, that is 500 milligram BD. Fine. So this is how you are going to remember how iron folic acid supplementation is given and what is the correct answer. You try to rule out the options, you will come to know the correct answers. Okay. According to MTP Act 2021, Which of the following statement is not correct? Unmarried females can undergo MTP without the consent of their partners. This is correct. MTP can be done up to 24 weeks. Yes, that is also correct. Breach of the women's confidentiality would result in fine or imprisonment of 2 years. No, the answer is imprisonment for 1 year. So this is the wrong answer. Only one doctor opinion is required up to MTP for 20 weeks. That is also correct. So A, B, D are correct answers. So answer to this question is C, which is a wrong statement. Fine, which is a wrong statement. When it is pregnancy between 20 to 24 weeks, okay, opinion of 2 doctors opinion is needed. Okay, when according to new MTP Act, 1 doctor opinion is sufficient when you are doing MTP till 20 weeks and 2 doctors opinion is required if it is 20 to 24 weeks. Okay, so wrong answer here is confinement or imprisonment is for 1 year, not for 2 years. Next, women with a prosthetic valve and on warfarin treatment for anticoagulation is now pregnant. What advice will you give? Okay, continue warfarin, wrong. No change in the treatment, wrong. Vitamin K is added, wrong. So the correct answer is when it is first trimester, always warfarin has to be stopped and heparin has to be started. Why heparin? Because heparin, low molecular weight, is the drug of choice in this case. Okay, and heparin do not cross placenta. मैम कुछ क्वेश्चंस FMGE से हाई लेवल नहीं इतना एक्सपेक्टेड है, इतना सब हमें आना ही चाहिए एंड दिस इज जस्ट अ क्लिनिकल वे ऑफ प्रेजेंटेशन फ्रेंड्स. सिंगल लाइनर्स, इमेज बेस्ड क्वेश्चंस, concept based questions you have already attended and prepared very well. Let me tell you, Obs Gynae is a very scoring subject, and if there are 30 questions in your exam, you should get 30 out of 30. Okay, because you know, like, you have a very good command on the subject. Okay, so try to rule out the options, you will get your correct answer. Now, in less than 12 weeks of pregnancy, a female with a prosthetic heart valve, you have to give heparin, low molecular weight. 12 to 36 weeks, you give warfarin. Now, why warfarin has to be added? Because now there will not be any teratogenic effect as organogenesis has already been done. So, you can very well put the patient on warfarin. Now, 36 weeks to delivery. 36 weeks to delivery, you add heparin. After delivery, you give warfarin. After delivery, you give warfarin. So this is how you are going to remember. Now my question is, why you are introducing in the 9th month of pregnancy heparin again? Why can't you continue with warfarin? Because bleeding tendencies in the neonatal brain has been increased when you give warfarin in the 9th month of pregnancy. So first trimester heparin, then 12 to 36 weeks warfarin, then last month of pregnancy heparin, after delivery again warfarin. So that is the way you are supposed to revise and remember. Next question, a lady with 38 weeks of pregnancy was admitted in view of first episode of painless bout of bleeding. So she is already a term pregnancy, and if it is a high risk pregnancy, you can do termination of pregnancy because already the lungs are mature. So she has painless causeless bleeding, hemoglobin is stable at this point of time, blood pressure is also normal, uterus is relaxed, head is not engaged. So head in this case, fetal head is high floating. So one of the reason for such a presentation is low lying placenta. So it is a case of placenta previa which is bleeding after 38 weeks of pregnancy. Fetal head is high floating. So when she is bleeding, already there is 38 weeks of pregnancy. You cannot wait for next bout of bleeding. You check her records. What is the type of placenta previa it is? You don't have to send the patient for a repeat ultrasound. If she is already carrying मैम कुछ क्वेश्चन FMG से आते हैं. So all of you are right. Dr. Surbi, Dr. Ali, Dr. SK, Dr. Mithu, all of you are correct. This is a placenta previa and she has come to you with bleeding. So I am going to do a cesarean section. Okay. I don't want to waste my time and I don't want the patient to be at risk. मुझे patient को भी risk पे नहीं डालना है. So if the pregnancy is term, हो सकता है ये central placenta previa और major placenta previa. That is why even at 38 weeks term pregnancy the head is free floating because there is placenta there and it is not allowing the fetal head to go down. So I am going to plan a cesarean section in this case. Okay, I am going to plan cesarean section in this case. Now, a 24-year-old pregnant lady at 11 weeks of pregnancy came to OPD with regular antenatal checkup. What is the period of gestation? 11 weeks. Mind it, organogenesis is still going on. She gave a history of thyroid dysfunction. She has thyroid disease. She is now worried about pregnancy. TSH level is 2.2 milli-international units per liter. What would you advise? Reassurance as TSH is normal. Okay. So this is normal range for TSH. So I am going to continue this pregnancy and time to time I can repeat the TSH levels, and if it is deranged, that means if it is elevated, then I am going to put the patient on levothyroxine. Fine. But this is normal, so I am not worried. I will allow this patient to continue the pregnancy. At 18 weeks or 20 weeks, I am going to get a level 2 ultrasound done to rule out congenital anomalies, and time to time I keep on getting the TSH levels done. If the value is deranged, only then I am going to give her medication, otherwise not. Next, a female with 33 weeks. First tell me if the patient is having hyperthyroidism in pregnancy. What is the drug of choice in the first trimester of pregnancy? You can write down in the chat box, what is the drug of choice in first trimester of pregnancy? Answer is PTU, that is propyl thiouracil. Propyl thiouracil. In the second trimester, in the third trimester, you can give carbimazole or methimazole. These two drugs cannot be given in first trimester. Okay. These two drugs cannot be given in the first trimester. Now next, a female with 33 weeks of period of gestation was diagnosed with eclampsia. Okay, so she has convulsions. Magnesium sulfate has been started and it is a pre-charge regime which we follow. What is the loading dose of magnesium sulfate? So what is pre-charge regime? Pre-charge regime is you give 4 gram of 20% magnesium sulfate IV slowly. Then you add 10 grams of 50% magnesium sulfate IM. 5 grams in each buttocks. This is the loading dose. Now after 4 hours, you are going to give maintenance dose. Okay, that is 5 gram 50% intramuscular. Okay, after checking, what do you check? Knee jerk, respiratory rate and urine output. Knee jerk should be present, respiratory rate should be normal and urine output should be more than 100 ml in 4 hours. more than 100 ml in 4 hours. Okay. So if every parameter is all right, so you give 5 gram 50% magnesium sulfate in alternate buttocks. This time right, next 4 hours left, then right, then left. Till how long? Till 24 hours of delivery or 24 hours of last convulsion. Now, what is the antidote of magnesium sulfate and what is the mode of excretion? Calcium gluconate is the antidote of magnesium sulfate, and magnesium is excreted through the kidneys. So, always put in a Foley's catheterization and urobag and monitor the urine output. If urine output is very less, then you stop magnesium sulfate and replace it with another anticonvulsant, which is injection phenytoin. So this is the precharge regime. Let us see the question. 6 gram IV with 10 gram of in buttocks? No. So the answer is 4 gram IV with 10 gram of magnesium sulfate intramuscular in the buttocks. I am sure every one of you knows this answer. Yes, Dr. SK, Dr. Mithu, Dr. Surbhi, Dr. Ali, all of you are right. Okay. Dr. Z, you are also right. Calcium gluconate. Next. A woman with 8 weeks amenorrhea presents with complaints of lower abdominal pain on right side. On examination, she had pallor. Pallor, amenorrhea, and patient 90/50. According to me, my diagnosis in this case is ectopic pregnancy. It is ectopic pregnancy. Since she is in shock, so might be there is a rupture ectopic or it is in the process of rupturing. Okay. So since she is a young patient, here the age of the patient was also written and it is a primi gravida patient. So you want to save the tube. So what has to be done? You have to do resuscitation first. Resuscitation. Okay. Arrange blood. Take consent and shift to OT. So I am going to do the tubal conservative surgeries. So I am going to do salpingostomy. Okay. Salpingostomy means I am going to give a nick, take out the ectopic pregnancy and do not stitch it. Let it heal by secondary intention. जितना स्टिच करते हैं उतने एडिशंस बनते हैं एंड मे इंक्रीज द चांस ऑफ इंटेस्टिनल ऑब्स्ट्रक्शन और इनफर्टिलिटी. सो द मैनेजमेंट इन दिस यंग फीमेल, this diagnosis is ectopic pregnancy. Okay, and if you have time you can get a bedside ultrasound done yourself. Okay, but don't shift the patient here and there. First of all, start IV line, take the blood sample, arrange the blood, do resuscitation, and then take a high risk consent, shift to OT, and either you do laparoscopy or laparotomy depending upon the competence of the gynecologist. Okay, and wherever possible do save the fallopian tube. If it is a badly ruptured fallopian tube, patient's BP is like 60/40 or 60/20, okay, then I am going to do a complete salpingectomy. Okay, so in that case tubal conservative surgeries will not be feasible in that patient. Fine. So which type of ectopic pregnancy ruptures earliest is ischemic rupture of ectopic pregnancy. Okay, it ruptures in less than 6 weeks. Which of the ectopic pregnancy ruptures late is interstitial 3 to 4 months. Which is a dangerous ectopic pregnancy? Answer is interstitial. Which is a dangerous ectopic pregnancy? Answer is interstitial. Okay. So dangerous ectopic pregnancy is interstitial. interstitial is a dangerous ectopic pregnancy because when the pregnancy occurring here, this baby can grow in the uterus, and when it ruptures, it gives a intraperitoneal bleed. Intraperitoneal bleed. Okay. So sometimes if you are not able to control the bleeding, you might have to do a life-saving hysterectomy. So dangerous ectopic pregnancy is always interstitial ectopic pregnancy. So earliest to rupture is isthmic, late to rupture is interstitial, dangerous ectopic pregnancy is again interstitial. Now, which of the following statement is false about the active management of third stage of labor? Active management of third stage of labor we have already studied, that is according to WHO. So there are 4 components: intramuscular, oxytocin, bolus, 10 units you have to give after the delivery of the baby. Number 2, you have to deliver the placenta by controlled cord traction method. Number 3, you have to do delayed cord clamping, that is cord clamping is done between 1 to 3 minutes. Okay, it will transfer extra 80 to 100 ml of blood from mother to fetus. Okay. Number 4, intermittent uterine tone assessment. Uterine massage is not a part of active management, it is a part of atonic PPH management. So intramuscular bolus, I have told you it is 10 units intramuscular which is given. So that is a wrong answer. Delivery by controlled cord traction correct, delayed cord clamping correct, intermittent uterine tone assessment is also done. Okay. Uterine massage is not included, that is the management of atonic PPH. Okay. So how much oxytocin should be given? It is 10 units intramuscular. Fine. Next, 16 weeks of pregnancy, a lady presented with the complaints of bleeding per vaginum and pain. On examination, height of the uterus is equal to the period of gestation. Okay, and the cervix is open. So there is amenorrhea, 4 months amenorrhea, bleeding per vaginum, pain and cervix open, but period of gestation is equal to height of the uterus. I did, Dr. SK is writing, I did the many times revision and also 5th year PYQs, but I didn't improve. अरे कोई बात नहीं यार, this test is for your revision as much as if the LN is providing you the facilities to revise again and again, why not do it? So whatever questions are being discussed, remember paper 1 you have to do very perfectly because clinical आप कर लेते हो, but paper 1 के subjects में sometimes you know like you get lost. Okay, so you have to get marks in paper 1 as well as paper 2, both the papers. Fine. So only clinical will not help, only single Obs Gynae will not help. Gynae will always help you to improve your marks and it will build up your confidence. But if paper 1 you have done badly, then you cannot expect out of 150 you get 120 marks in second paper and just 30-40 marks in the first paper. That is not done. Always you get pre and para clinicals in the first paper and clinicals in the second paper. So always it is important for you to you know like do the first paper best and then second automatically you are doing your best because clinical sense you have already got it. So just forget about if anybody has already given an attempt and whatever marks are there, always work upon your weak points and weak subjects. So whichever place you have read it, okay, just these sessions are going to help you just boosting up your confidence and do revise all the tests which you have given. Fine. So this appears to me inevitable abortion because cervix is open. Now what is the management for inevitable abortion is D&E by using the ovum artery forceps. D&E by using the ovum artery forceps. All of you, Dr. Mithu, Dr. Surbhi, Dr. Gupta, Dr. Doc, Dr. SK, Dr. Suresh, all of you are writing the correct answers. Now 19-year-old unmarried girl is brought by her mother in the OPD. Concern is on frequent menses. Asking the detailed history, the menses is 20 to 24 days cycle, which is absolutely normal cycles. This is normal cycles. Okay, menses are regular, moderate to heavy, last for 4 to 6 days. 4 to 6 days is also normal. How will you manage this case? This is reassurance, because in young patients sometimes the cycles can be anovulatory. So if you want the periods are very heavy, you can give hemostatic drugs. Hemostatic drugs, but no need to put her on any hormones. Okay, in just next few cycles she will be better, plus you can add her hemetinics so that she should not develop anemia. Okay, rest is reassurance. Unmarried girl, you never do TVS. Ultrasound, you're not going to gain anything, because it appears to me just a hormonal ratio has been altered, just an hormonal imbalance, or maybe the cycles are anovulatory. Okay, so just a reassurance, hemetinics and hemostatic drugs, that is all what is to be needed in this patient. If this patient would have come every 10 days she is bleeding, or every 15 days she is bleeding, and she is bleeding continuously, then we might have to put her on hormones, but not in this case. Next, a patient came for a routine checkup, and it was found that cervical lesion 2/2. On the cervix there is a lesion on the anterior lip of the cervix. On per vaginal and per rectal examination, both parametrium are free. Ultrasound KUB shows hydronephrosis. Friends, when it is hydronephrosis, kidney involvement, it is already stage 3B cancer. Stage 3B cancer cervix. Okay, because there is a lesion 2/2 on the cervix, there is bleeding, and rectum examination shows parametrium is free, but KUB shows there is hydronephrosis and kidney involvement is there. So kidney involvement is always stage 3. So in this case, she is suffering from stage 2A1. She should undergo a pelvic MRI. This is correct, which is wrong statement. Okay, she will receive external radiation and brachytherapy, correct. She will receive chemo radiation. These all are correct. She is not suffering from stage 2A. She is suffering from stage 3B, because kidney involvement is stage 3B. So do revise the FIGO staging. That is very, very important. So in cases of stage 2B, stage 3 and stage 4 cancer cervix, the answer is concurrent chemo radiation. Concurrent chemo radiation and the radiosensitizer drug. Radiosensitizer drug is cisplatin. Also remember, stage 1B3, stage 2A2 also requires concurrent chemo radiation, because these are bulky tumors, do not respond well to surgery, and the size of the tumor is more than 5 centimeter. Okay, so what is chemotherapeutic drug used as a radiosensitizer? Answer is cisplatin. What is the management of stage 1B3, 2A2, stage 2B, stage 3, stage 4 cancer cervix? Is chemo radiation. Fine. Next, all of the following are the symptoms of endometriosis except, okay, dyspareunia, dysmenorrhea, infertility. This is a classical triad. Okay, vaginal discharge is not the feature of endometriosis. What is the most common symptom? Is pain. What type of pain? Congestive dysmenorrhea. What is the most common site for endometriosis? Ovary. That is chocolate cyst. What is the gold standard investigation for endometriosis? Is laparoscopy. Okay. What is a drug to treat endometriosis? GnRH analogues. Okay. GnRH analogues. And what is the treatment of infertility? Infertility in endometriosis, for mild endometriosis, you can try laparoscopy and laparoscopically adhesiolysis, but usually here it is clomiphene citrate plus IUI, intrauterine insemination. And if it is moderate to severe endometriosis, your treatment of infertility includes IVF, because there are very, very dense adhesions. If you try to remove or do the adhesiolysis, you will cause bladder and bowel injury. Okay, so better not try that. You can just offer her IVF, in vitro fertilization. Next, 56-year-old patient diagnosed with grade 1 endometrial cancer on endometrial sampling. MRI was done and showed mass less than 50% myometrium involvement. There is a mass, and that mass is involving 50% of the myometrium. So it is stage 1A. This is stage 1A. So treatment for this is total abdominal hysterectomy with bilateral salpingo-oophorectomy and removal of the lymph nodes. Yes, MRI is important, because if it is a clear cell carcinoma, most common type of endometrial cancer is endometrioid adenocarcinoma. So where prognosis is little bit better, poor prognosis, and where the extensive surgery, chemo, radiation, everything is given, that is clear cell carcinoma or papillary serous carcinoma of the endometrium. So that carries the poor prognosis and they are fast growing. Clear cell carcinoma or papillary serous carcinoma are fast growing tumors. So apart from surgery, chemotherapy, radiotherapy is also given for these tumors. Still the prognosis is bad. Next, what does AMH value of this represent? AMH का मतलब क्या है? AMH is anti-Mullerian hormone. Anti-Mullerian hormone. Anti-Mullerian hormone in the males is secreted by Sertoli cells at 7 weeks of pregnancy. What does this anti-Mullerian hormone do? It inhibits Mullerian duct. So in the males there is no uterus. Anti-Mullerian hormones in the female is secreted by granulosa cells at puberty. Okay, and AMH will tell you the ovarian reserve. So AMH, anti-Mullerian hormone, AMH more than 1 nanogram per ml is good ovarian reserve. Ovarian reserve means number of follicles in the ovary. Okay, AMH less than 1 nanogram, it is poor ovarian reserve. So in infertility investigations, AMH is also done and normal value is more than 1 nanograms. Okay, anti-Mullerian hormone is not cycle dependent. AMH can be done anytime. It is not cycle dependent. Like FSH you have to do on day 3. Okay, so some hormonal levels when you want to get it done, it is to be done on specific days, but AMH can be done on any time. It is not affected by feedback inhibition. Next question. 50-year-old female complains of amenorrhea for 6 months, prolonged spotting for 3 months. She is found to be obese and diabetic. Amenorrhea, prolonged cycles, obesity, diabetes. She has PCOD and uterus is normal. Speculum examination is normal. Endometrial thickness is 6 mm. Okay, so there is history of obesity, diabetes, PCOD. She has postmenopausal bleeding. Postmenopausal bleeding. This is all high risk for endometrial CA. High risk for endometrial CA or endometrial hyperplasia. So first investigation is done is transvaginal scan for endometrial thickness. Here it is given 6 mm. So next is you have to do endometrial sampling or DNC using an endometrial pipil or Carman's cannula, and you look for the histopathology report. Okay, depending upon the histopathology report, you are going to do the management. So here the question is endometrial biopsy with a pipil you have to do, because you have to rule out endometrial hyperplasia and endometrial cancer. Next, 23-year-old female presented with greenish offensive discharge, irritation, itching. Okay, so this is vaginitis and most probably it is trichomoniasis, strawberry spots. So trichomoniasis. Okay, which color kit you are going to do? NACO has, according to NACO, there is sexually transmitted infection, reproductive tract infection or Suraksha clinic. So they say minimum investigation and treat your patient. So there are different color kits available where the medicines are there. So this is vaginitis, and for vaginitis we use green color kit which contains metronidazole, doxycycline for 14 days, metronidazole for 14 days and cefuroxime. Okay. So this medicine is for vaginitis and this history is suggestive of trichomoniasis. Drug of choice for trichomoniasis is metronidazole. Okay. So green color kit has been given when it is vaginitis. Okay. Next, 15-year-old female presented with primary amenorrhea. She has periodic pain. Periodic pain का मतलब होता है cyclical pain abdomen for last 6 months, but she is not been bleeding. And what is this image showing? This image showing is imperforate hymen. So you have to get an ultrasound done because there may be any genitourinary anomalies. And finally the treatment is cruciate incision and drainage. So cruciate incision and drainage is the correct answer. Since the karyotype of this patient is 46XX, so she has uterus, she has ovary, so all the Mullerian duct derivatives plus the gonad is the female and karyotyping is female. So just giving a cruciate incision and drainage will be helpful. Here no role of gonadectomy. When it is pseudo-hermaphrodites, only then gonads are removed because that is a risk factor for malignancy. Here nothing such things is happening, only cruciate incision and drainage. Which of the following congenital anomalies will result when the Mullerian duct fuse? There are 2 Mullerian ducts. Okay, if there is no male hormones in the intrauterine life, these Mullerian ducts, they fuse and they form single uterus, fallopian tube, cervix and upper portion of vagina. Lower portion of vagina arises from urogenital sinus. So these Mullerian ducts have formed half uterus, cervix, fallopian tubes, okay, and ovary is the gonad, ovary. Okay. So if, and there is septa and there is here. So this septum resolves after 2 weeks. If both the Mullerian duct makes their own uterus, fallopian tube and cervix and vagina. So this type of uterus is called as uterus didelphus. This is called as uterus didelphus. So the correct answer is uterus didelphus when the Mullerian duct fails to fuse. If the septum does not resolve, then it is called as septate uterus. Most common uterine anomaly causing recurrent abortions or infertility is a septate uterus, and investigation is hysteroscopy, laparoscopy, which is a gold standard because you are going to treat the Mullerian duct anomalies by doing lapro and hystero. 22-year-old female comes in the emergency. She is asking for an emergency contraception within 8 hours of assault. So what emergency contraception you give? I have already been telling you in my classes. Emergency contraception most commonly given is LNG pill within 72 hours of unprotected coitus, 1.5 gram stat single dose. But the best emergency contraception is copper T, can be applied within 5 days of unprotected coitus. Next, which of the following organs in the female is homologous to penile urethra? Like ovary is homologous to testis, okay. Clitoris is homologous to penis. Then labia majora in the female is homologous to scrotum, and labia minora is homologous to penile urethra. So penile urethra, it is labia minora. Fine. For penile urethra, it is labia minora. 24-year-old female presents with the complaints of irregular vaginal bleeding for 1 year. She got her periods 3 to 4 months back. She needs medication to induce bleeding, and she has prolonged heavy cycles for 10 to 15 days. She has weight gain, facial hair, that is hirsutism, plus menstrual disturbance, okay. Plus she keeps on developing secondary amenorrhea. So this is a case of polycystic ovarian disease unless proved otherwise, okay. Next, which of the following structure prevents uterine prolapse most effectively? Always remember, if they are not asking the muscle, they have asked the ligaments. Then here is the cardinal ligament, which is holding the uterus and cervix from both the sides. So cardinal ligament, which is also called as McEnroth's ligament, which is also called as McEnroth's ligament. So this is the most important ligamentary support to the uterus, and most important muscular support. Most important muscular support is levator ani muscle. Fine. Which is the ligament that prevents retroversion? Prevents retroversion. Students, do you know the answer? Which is the ligament that prevents retroversion of the uterus? Answer to this question is round ligament holds the uterus in anteverted, anti-flexed position. And number 2 is uterosacral ligament. It prevents the retroversion. So whenever uterus changes to retroverted state, genital prolapse can result. 32-year-old female presents with previous 2 cesarean section, heavy menstrual bleeding for 6 months, worsening of dysmenorrhea. 2 cesarean है, heavy bleeding है, worsening of dysmenorrhea, uterus is 12 weeks, uniformly enlarged. Uniformly enlarged word is used when the myometrium is thickened. Okay, so thicker myometrium, irregular endomyometrial junctional zone. So this is no other than adenomyosis. This type presentation is for adenomyosis. If it is irregularly enlarged uterus, then it will be fibroid. Okay, if uterus is normal but there is retroverted and it is fixed, or there is mobility restricted, or there is tenderness in pouch of Douglas, or there is bilateral adnexal masses, then we write it is endometriosis. So this history, uniform enlargement of uterus and like menstrual disturbance, this appears to me adenomyosis. Patient has been advised a karyotype after hormonal evaluation for primary amenorrhea. Absence of secondary sexual characters by age 15 and karyotype is 45XO. So this is most likely a Turner syndrome where there is streak ovaries. There is no breast development and there is no breast development and there is stigmata. There is stigmata, okay, of the Turner syndrome. So always remember, in such cases there is high FSH and high LH, okay, or you can say high FSH and low estradiol. So it is hypergonadotropic hypogonadism. Hypergonadotropic hypogonadism. That is what you get this picture in a Turner's syndrome. So that's all from this session. I hope this is going to be useful to you, because so many questions has been framed in a clinical scenario. So even if there is a long statement questions, you are able to mark. So do your Obs Gynae subject the very best. Keep on revising the tests and discussion, and do not follow any new notes. Whatever you have revised, revise that, but as many questions as you can do. So all the best for your upcoming exam.